Welcome back to the deep dive. Today, we're jumping into something, well, frankly, quite terrifying. A neurological condition that moves fast.
Really fast. We're talking about a situation where the body's own immune system suddenly goes rogue and attacks the nerves.
Leading to rapid paralysis. It sounds like something out of a movie.
It does. We're taking a deep dive into Guillain Barré syndrome, GBS, and our goal today really is to understand it from trigger to treatment.
Focusing on what matters most clinically.
Exactly. Why does it happen? How do we spot it quickly? And critically, how do we manage that immediate danger, especially breathing failure?
Okay, so let's start with the basics. Our sources define GBS as, let me get this right, an acute, monophasic, immune-mediated polyradiculoneuropathy. That's a lot.
It is a mouthful, isn't it? But let's break it down. Acute means it comes on quickly.
Right, and monophasic.
That means it's typically a one-time event, one episode. It usually flares up after, say, a stomach bug or a respiratory infection.
Okay, and the polyradiculoneuropathy part?
That just tells us what is being attacked. Multiple peripheral nerves and their roots. But the real question, the why, comes down to something called molecular mimicry.
Molecular mimicry. Okay, let's unpack that. That sounds like the key to understanding the whole thing.
It really is. Think about it like this. Your body fights off an infection, maybe Campylobacter jejuni, a common bacteria.
One that causes food poisoning.
That's the one. So your immune system makes antibodies to fight that bug. But here's the problem.
Uh-oh.
Parts of that bacteria look almost identical, molecularly speaking, to parts of the myelin sheath covering your nerves.
The insulation on the nerves.
Exactly. So the immune system, in its effort to clear the infection, gets, well, confused. It sees the nerve sheath and thinks, hey, that looks like the enemy, and starts attacking it too.
Wow. So it's a case of mistaken identity at a molecular level.
Yeah.
That makes so much sense. So what are the usual suspects? The triggers. You mentioned Campylobacter.
That's probably the most common one we see, but others pop up frequently too, like mycoplasma pneumonia.
Another respiratory bug.
Right. And viruses like cytomegalovirus, CMV, Epstein-Barr virus, even HIV.
And thinking about recent events, we should also mention Zika and SARS-CoV-2. The sources link those as well.
Absolutely. Less common, but definitely relevant triggers. And it's not always an infection causing illness.
What do you mean?
Well, rarely, very rarely, something like the influenza vaccine, which is designed to provoke an immune response, can accidentally trigger this same kind of aberrant attack.
Okay, so the immune system gets triggered, makes a mistake.
Yeah.
What does that look like for the patient? What's the story they tell?
The classic picture is rapid progression. They'll describe tingling, numbness, then weakness.
And crucially, it moves in a specific way, right?
Yes, the ascending pattern. That's key. It usually starts in the feet and legs, then marches upward over days, maybe to the trunk, the arms, even the face.
You use that electrical cable analogy before the axon wire. Myelin is the insulation.
Right. And in the most common type, ADP, acute inflammatory demyelinating polyradiculoneuropathy, the immune system strips off that insulation, the myelin.
So the signal gets weak or slow.
Exactly. But in some forms, the axonal variants, it actually damages the wire itself, the axon. That's generally more severe. It takes longer to recover from.
It's not just about weak muscles, though, is it? What other early signs should we look for?
Back pain is surprisingly common, sometimes really severe, actually. And you often see cranial nerve involvement pretty early on.
Like what?
Things like blurred or double vision, difficulty swallowing or speaking, those are big warning signs. And sometimes bilateral facial weakness, like they can't smile evenly or close their eyes tightly.
Now, you mentioned mimics earlier. What tells us it isn't GBS? What should we not see?
This is so important. On exam, the patient should have a normal temperature. They shouldn't be febrile. And their mental status should be completely normal. Clear thinking.
Okay, so if someone has ascending weakness plus a fever, or they're confused,
then you need to think differently. Maybe viral meningitis, encephalitis, something infectious happening right then and there. GBS is, clinically cold. The inflammation is autoimmune, not an active infection in the nerves themselves.
Got it. And what do we find on exam that points strongly towards GBS?
You'll find that bilateral symmetric weakness and sensory loss often worsen the legs. Muscle tone might be decreased, but the absolute classic, the hallmark finding.
The reflexes.
Yes. Reduced or totally absent deep tendon reflexes. Oriflexia. It's like the signal just can't get through that damaged nerve.
Okay, so the clinical picture is strongly suggesting GBS. What's the next step? How do we confirm it?
We need to look at the cerebrospinal fluid, the CSF, so
Yeah.
a lumbar puncture, a spinal tap is usually the next diagnostic step.
And what are we looking for in the CSF?
We're looking for that classic aha finding,
Wow.
albuminocytologic dissociation.
Right, that term again. Break it down for us. What does that mean?
It sounds fancy, but it's simple, really. Albuminocytologic refers to protein, albumin, and cells, cytology. Dissociation means they're out of sync.
How so?
You find high levels of protein in the CSF, that's the albumin leaking from the inflamed nerve roots. But crucially, the white blood cell count is normal or only slightly elevated.
Because it's not an active infection in the spinal fluid.
Exactly. High protein, normal cells, that's the dissociation, and it strongly supports GBS.
But timing matters here, doesn't it? What if you do the tap too early?
That's a key point. If you do the lumbar puncture within, say, the first 48 hours, the CSF might still look normal. The protein hasn't had time to leak out yet.
And what about nerve conduction studies? EMG.
Same issue, potentially. Those electrodiagnostic tests might not show the characteristic slowing or blockage until about a week into the illness.
So what's the bottom line?
Clinical suspicion is paramount. If the story fits, the exam fits, and the patient is getting worse, you don't necessarily wait for the LP or EMG results to come back positive. You often need to start treatment based on that strong clinical picture.
Okay, let's talk about what isn't GBS. What are the red flags in those tests that point away from it?
Well, if that CSF comes back with a really high white blood cell count, that shouts infection, not GBS. Think meningitis or myelitis.
Makes sense. Anything else?
On the EMG and nerve conduction studies, if they show a pattern suggesting the muscle itself is the primary problem, a myopathic pattern, then you're looking at a myopathy, not a neuropathy like GBS.
And other conditions can mimic the weakness pattern too, right?
Definitely. Things like botulism, which affects the neuromuscular junction where the nerve tells the muscle to fire, can cause paralysis. Or, as we mentioned, direct viral infections of the spinal cord, viral myelitis. Different causes, different treatments.
So we've zeroed in on GBS. The immune attack is confirmed or highly suspected. Now, the focus shifts dramatically, doesn't it?
Absolutely. It becomes less about diagnosis and all about management, specifically preventing respiratory failure. This is where things get critical fast.
GBS is the most common cause of this kind of rapid, widespread paralysis. But the thing that can actually be fatal is the breathing stopping.
Precisely. The weakness ascends, and if it reaches the diaphragm and the muscles you use to breathe, that's a true emergency. So the very first step is always a rapid ABCDE assessment. Airway, breathing, circulation.
Checking for stability.
Exactly. And if there's any sign of instability, especially with breathing, you have to be ready to secure the airway. That might mean intubation and putting the patient on a ventilator.
And you can't just ask the patient, how's your breathing?
Right.
They might not feel short of breath until it's too late.
That's the dangerous part. Subjective feeling is unreliable here. The weakness can creep up quickly. That's why regular objective monitoring of breathing strength is non-negotiable. We use bedside pulmonary function tests, PFTs.
Okay, tell us about those. What are we measuring?
We're measuring how strong their breathing muscles actually are. Things like vital capacity VC, which is the biggest breath they can take in and blow out. Maximal inspiratory pressure, MIP, how hard they can suck air in, which reflects diaphragm strength. And maximal expiratory pressure, MEP, how hard they can cough or push air out, which is crucial for clearing secretions.
And there's a specific rule for deciding when to intubate based on these numbers, isn't there?
Yes, the 20-30-40 rule. This is a lifesaver in neuromuscular weakness. It gives us objective thresholds.
Walk us through it, 20, 30, 40.
Okay. If the vital capacity VC drops below 20 milliliters per kilogram of body weight, if the maximal inspiratory pressure, MIP, is less than 30 centimeters of water, or if the maximal expiratory pressure, MEP, is less than 40 centimeters of water,
then it's time.
Any one of those hitting the threshold means the respiratory muscles are failing, and it's time to strongly consider or proceed with intubation before they completely fatigue.
And this is so important. You absolutely should not wait for their oxygen levels to drop, right? Why is that?
Because oxygen saturation, what you measure with a pulse oximeter, is often totally normal until the very, very end. Hypoxemia, low oxygen in the blood, is a late sign in this kind of respiratory failure.
So if you wait for the O2 sat to drop,
You've waited too long, the muscles have already failed, you're behind the curve, and intubation becomes much riskier. You have to anticipate the failure based on strength measurements.
got it. Strength, not oxygen.
Yeah.
Now, breathing isn't the only danger zone. What about dysautonomia?
Right, that's the other big, often silent threat. The autonomic nervous system controls all the automatic stuff: heart rate, blood pressure, digestion.
And GBS can damage that too.
Yes. So patients can have wild swings in heart rate and blood pressure, really high, then suddenly really low. They can develop serious arrhythmias. Their bodies might overreact dangerously to medications that normally just tweak blood pressure a bit. It makes them very fragile cardiovascularly.
So constant monitoring is key there too. Now, earlier you mentioned different forms of GBS. It's not just one single entity.
Correct. It's more like a spectrum or a family of related syndromes. It depends partly on whether the immune system is mainly attacking the myelin insulation or the axon wire itself, and which nerves are hit hardest.
We talked about AD, the common demyelinating one with ascending weakness. What are the others?
Then you have the axonal variants, AMEN, acute motor axonal neuropathy, which is mostly weakness without much sensory loss, and AMSN, which is both motor and sensory axonal damage.
And those tend to be more severe.
Generally, yes, because the nerve wire itself is damaged, recovery tends to be slower and sometimes incomplete.
Okay. What about variants that affect the head and neck more prominently? Miller-Fisher syndrome comes up a lot.
Ah, yes, Miller-Fisher. It's quite distinct. It has a very specific classic triad of symptoms.
Okay, fair.
Ophthalmoplegia, meaning the eye muscles are paralyzed, they can't move their eyes properly, often side to side. Ataxia, which is profound incoordination and unsteadiness, like they're drunk. And areflexia, again, loss of reflexes.
So eyes, balance, and reflexes.
Yeah.
That's Miller-Fisher.
Exactly. And if you see that triad, plus the patient has impaired consciousness or drowsiness,
Then it's even more serious.
then we call it Bickerstaff brainstem encephalitis. It implies more widespread inflammation affecting the brainstem.
And one more distinction, you mentioned GBS is monophasic, one episode. What if it doesn't get better or comes back?
Right. If the symptoms keep worsening beyond about 4 weeks, or if they improve and then relapse, we're no longer calling it acute GBS. That shifts the diagnosis to CIDP, chronic inflammatory demyelinating polyradiculoneuropathy. That's the chronic version, and it needs ongoing long-term treatment.
Okay, so let's get to treatment for the acute phase for GBS itself. Once it's diagnosed or strongly suspected and the patient is admitted, what do we do to stop the immune attack?
But there are 2 main treatments, both considered equally effective. The goal is to basically get rid of or neutralize those harmful antibodies that are attacking the nerves.
And those are
Intravenous immunoglobulin, or IVAGA, which is basically giving concentrated antibodies from healthy donors to sort of overwhelm or block the bad ones.
Yeah.
Or plasma exchange, sometimes called plasmapheresis.
What does plasma exchange involve?
That's a procedure where the patient's blood is taken out, the plasma component containing the harmful antibodies is removed, and the blood cells are returned with replacement fluid, like an oil change for the blood, removing the damaging stuff.
Okay, IVAG or plasma exchange. Now here's the big question that always comes up. This is an inflammatory, immune-mediated disease. Why not use steroids? Like high-dose silomedrol. Isn't that standard for autoimmune flares?
You'd think so, wouldn't you? It seems logical.
Yeah.
But this is one of the most important high-yield facts about GBS management.
Okay.
Despite the inflammation, multiple large studies, good randomized controlled trials, have clearly shown that corticosteroids do not help in acute GBS. They don't speed recovery, they don't reduce severity.
Wow, so no benefit at all.
None shown. Some data even hinted they might slightly delay recovery, though that's less certain. But the bottom line is clear. Steroids are not indicated and should not be used for GBS treatment. It's IVIG or plasma exchange.
That's a crucial point to remember. Avoid the steroids.
Yeah.
So alongside the IVIG or plasma exchange, what else is vital? The supportive care must be huge.
Oh, absolutely critical, because these patients can be profoundly weak and immobile, sometimes for weeks or months. So number 1 is that ongoing respiratory monitoring we talked about and cardiovascular monitoring for dysautonomia.
Right.
Then, because they're not moving, the risk of blood clots, DVTs, is extremely high. So aggressive DVT prophylaxis blood thinners, compression devices is essential.
And skin breakdown. Pressure ulcers.
Huge risk. Meticulous skincare, regular turning, special mattresses, all vital to prevent pressure sores. And getting physical and occupational therapy involved early, as soon as the patient is stable enough, is key for starting rehabilitation and maximizing long-term recovery.
Okay, let's try to boil this down. Key takeaways. GBS. It's an immune attack triggered often by infection, causing that classic ascending weakness.
Right. Mistaken identity, molecular mimicry. Look for the pattern. Look for the absent reflexes, and crucially, don't look for fever or confusion.
And the CSF finding. High protein, normal cells, that dissociation.
Exactly. And the absolute critical management step. Watch the breathing strength like a hawk. Use the 20-30-40 rule for PFTs to guide intubation. Don't wait for oxygen levels to drop.
Treat with IVAG or plasma exchange, not steroids, and manage all the complications of immobility.
That sums up the core management pretty well.
So here's something to think about as we wrap up.
Yeah.
We know GBS can be triggered by common things, even occasionally a vaccine. And our treatment focuses entirely on cleaning up the mess after the immune system has made this mistake, removing antibodies, calming the system down.
Right, we're treating the consequence, not preventing the initial trigger confusion.
So looking forward, as we get better at understanding exactly how that molecular mimicry happens for each trigger, those specific immune pathways, could that lead to, I don't know, more targeted therapies, maybe ways to prevent the immune system from making that mistake in the first place, especially if we know someone's just had a triggering infection?
That's the hope, isn't it? Moving from reactive treatment to perhaps proactive prevention or much more specific immunomodulation. Definitely something to keep an eye on in future research.
Something to mull over. Thanks for joining us for this deep dive.
My pleasure.